Pre-hospital monitoring refers to the process of assessing and tracking patient vital signs and other health indicators before they reach a hospital setting. This typically occurs in ambulances, helicopter, or other emergency medical service vehicle during transport to healthcare facility. Vital signs: heart rate, blood pressure, respiratory rate, oxygen saturation, temperature. Heart rate monitored with the ECG to assess heart function and rhythm. Blood pressure measured periodically to assess circulation and potential fluid imbalance. Respiratory rate and oxygen saturation measured with the pulse oximeter to assess lung function and oxygen delivered to tissue. Temperature can indicate infection or other underlying issue. Additional monitoring: blood glucose, particularly important for diabetic patients who experience altered mental status, and tidal carbon dioxide can provide insight into cardiac output and resuscitation effectiveness. Pain assessment help guide pain management intervention. Neurological assessment evaluating the level of consciousness, pupil size, and other neurological functions. Benefit of pre-hospital monitoring: early identification of critical changes, allows for prompt intervention and potentially improve patient outcome. Also, better preparation for arrival at the hospital, provide valuable information to emergency room staff for immediate management. Improved communication enable real-time update on patient status between paramedic and hospital. The role of monitoring is to provide a real-time visual display of patient physiology and to alert the clinician when this falls outside the predetermined limit. The pre-hospital environment presents a challenge when assessing, training, monitoring patients. This and the need for rapid assessment often lead to compromise between what is desirable and what is practical. Indeed, there are situations where the time taken to place monitoring in the is for great risk than benefit to patient. For example, if a patient with penetrating chest injury is convalescent and close to defined care, when the equipment for rapid transfer over the desire for full accurate physiological measure. Pre-hospital monitoring: the same physiological variables should be monitored as in the station room: pulse, oxygen saturation, ECG, blood pressure, respiratory rate, conscious level, temperature, and in the tidal carbon dioxide. Patient transfer between clinical treatment, physical blood pressure, central venous pressure, urine output may also be monitored. The clinician need to make an active choice for which variable to monitor and what alarm limits. Multi-modiate monitor allow different physiological variables to be displayed simultaneously on a single screen, assigning defined colors to different physiological variables aid clarity and safety. Multi-modality monitors. Significant fluid shift may occur during takeoff and landing on a retrieval flight. Vibration and motion in moving ambulance or helicopter may render non-invasive blood pressure virtually redundant. The human equipment interface. Clinicians routinely respond to clinical clues, alarm, and alert that occur during patient care. They appraise the situation, assess the significance of the warning, and make a decision to either intervene or continue monitoring the situation. Here, all monitor equipment need to be easily accessible and visible. Ideal characteristic of pre-hospital monitoring equipment: loud and visible, large and clear, simplicity of operation, equipment characteristic: lightweight and power supply. The structure approach to monitoring. The best monitor remain the clinician. Initial assessment may occur when the patient is trapped or partially visible to the clinician and need to be regarded as a baseline monitoring. As the environment becomes more oppressive, access to the patient improves. Airway. Clinician assessment is made for the adequate ventilation, breathing, monitoring. Begin respiratory rate. This arguably most sensitive detector of cardiovascular compromise. Pulse oximetry. This provides an non-invasive continuous read out of oxygen saturation. Pulse oximetry and wavelength, and here the wavelength and absorption. Here the normal rectangular capnography waveform, respiratory baseline, expiratory baseline, expiratory plateau, and end tidal normal capnography waveform. Here SO2 in real time, or esophageal intubation, cardiac arrest, air leak, hypoventilation, hyperventilation, rebreathing, obstructed ET tube, ventilatory effort, abnormal capnography waveform. Capnography qualitative and quantitative measure are widely used. The latter is arguably the single most useful piece of monitoring available in prehospital care. Has measured the end-tidal carbon dioxide normal range 35 to 45 milligram. Leaves and waveform analysis provide information on confirmed tracheal intubation, respiratory rate, airway endotracheal tube obstruction, ventilator, muscle relaxation, cellular function, cardiac output. The waveform may display ET CO2 as a function of expired volume. Also, we assess circulation, pulse, electrocardiogram, is electrocardiogram, capillary refill, pressure sufficient to balance the center area of skin, such as over the sternum, is applied for 2 seconds, then released. The time taken for normal color to return is counted, with a normal value being 2 seconds or under. Longer refill time suggests impaired perfusion in sepsis and hypovolemia. Non-invasive pressure. The cuff should be 12.5 cm wide, with 40% of the mid-arm and the arm placed at the same level as the heart. If the cuff is too small, blood pressure will be overestimated. Invasive blood pressure. The noise and the vibration may all transport modalities interfere with the NIBB and make IV be attractive for patient transferred between hospital. And monitoring environment, temperature, monitoring in the aircraft, the function of medical equipment as well as logistic consideration are of great importance when deliver medical care in aircraft. Also, future monitoring technologies providing an even increasing array of monitors and new application of current technology. Conclusion: your clinical skills are your best monitor. Learn to trust them, high-end monitor built on clinical assessment but never replace it. Monitor may not always be required like any intervention in medicine. Pre-hospital monitoring can have the added complexity of the artifact and interference. Look at the whole. Never ignore an abnormality, explain it. There is emerging evidence that even a single reading of low blood pressure is associated with increased mortality. Know your monitor and check the alarm before you leave. Thank you.